So this is going to be the recorded lecture for the second half of Chapter 10, and in a separate segment I will do a lecture segment for Chapter 11. So we start this section with the clinical considerations for antimicrobial drugs in terms of being used in a patient. And listed here are the ideal characteristics of an antimicrobial drug. It should be readily available, inexpensive, chemically stable, easily administered, non-toxic to the patient and non-allergenic to the patient, but selectively toxic against the pathogen that it's intended to kill. The problem is that most drugs, some drugs can't fit or can't meet all of these requirements. But this is the ideal list of characteristics for a drug. So a lot of times we're going to be talking about, when we talk about antimicrobial drugs, we're mostly talking about antibiotics, which act against bacteria. And the spectrum of action of an antibiotic can be categorized as either narrow spectrum or broad spectrum. And there are times when you want to use a narrow spectrum antibiotic, especially if you know pretty specifically what organism is causing an infection. And there are other times when you need to use a broad spectrum antibiotic, especially right at first when you have not identified the exact pathogen, but you want to get the patient started on a medication to help them fight the infection. One of the problems with a broad-spectrum antibiotic, though, is that it wipes out not only the pathogens, but also the normal flora, the good bacteria. And what that does is it opens up an opportunity for what we call secondary infections, opportunistic infections that develop sometimes after the administration of the antibiotic. The effectiveness of a drug is called the Kirby-Bauer test that we did in lab. And the Kirby-Bauer test, you spread the pathogen on a plate, you put the different discs on the plate for the different antibiotics, and then you measure the zone of inhibition. Usually you're going to choose the antibiotic that has the most effective, it is most effective against that antibiotic, so you would pick the antibiotic that has the largest zone of inhibition, probably. Of course, that would depend on whether or not the patient is allergic to that antibiotic, but in general, you're going to pick the one that has the largest zone of inhibition. And that is one way that the effectiveness of an antibiotic can be determined. But in the lab at the hospital, they're not going to be growing the bacteria on plates typically. They're going to do a different type of test, although it's based on the same logic. But they're going to do what's called the minimal inhibitory concentration test. And it's fundamentally, and that's up here on the top picture, fundamentally it's just like the Kirby-Bauer test, and what you do is on each row, so this is a little plastic plate that has teeny tiny test tubes, and they're organized in these rows. And so let's say on the top row, let's say you have penicillin, and on the far left you have a very high concentration, or actually in this picture, on the far left you have a very low concentration of penicillin, and on the far right you have a very high concentration of penicillin in the tube. So as you move from right to left, the concentration becomes more and more diluted. Or another way to say it is, as you move from left to right, the concentration of penicillin is increasing. And typically, you'll be growing the same pathogen in every well, so you'll inoculate all the wells with the same pathogen. But the pathogens will be growing in environments that have, as you move across this row, increasing amounts of the drug. And so at the lowest concentration of the drug, here on the far left, the bacteria can grow. Maybe in the next well, just next to it. But at some concentration, you reach a point where the bacteria cannot grow. And that is that point at which the concentration of the antibiotic is enough to kill or at least stop the growth of the bacteria. So in the wells that the drug is too diluted, the bacteria can grow and they become turbid, cloudy. And then you reach a point where all the wells are clear, meaning you've reached a concentration above which the bacteria cannot grow. And that transition point between having the point where you have a clear well and the next well is cloudy, somewhere in between that, or somewhere at that point, you have the drug concentration that is the smallest amount needed to stop the growth of the bacteria. So this is called the minimum inhibitory concentration test, because it helps you to find what's the minimum amount of the drug that I would need to give to the patient to stop the growth of the bacteria. So the minimal bactericidal test is where the level of the drug has become so much that you have no colonies. So minimal inhibitory concentration just means growth is inhibited, but not necessarily all the cells are killed. Minimal bactericidal test tells you what concentration you need in order to get no colonies on a plate. So typically those kinds of tests are going to help guide the doctor in deciding what the concentration of drug needs to be for the patient. Okay, so the routes of administration of drugs should probably pretty familiar to you. Topical is application out on the skin, for example. Oral means you swallow something. Intramuscular would be an injection into muscle. Intravenous would be an injection directly into a blood vessel. But what you might not be familiar with is the curve here of how the concentration of the drug is in the blood over time. So the y-axis is the concentration of the drug in the blood, and the x-axis is time. And this is a very general graph. Of course, it would be a little bit different depending on the drug. But when you do a topical application, you don't get anything in the blood, or a very small amount, if anything, makes it into the blood. If you do an oral, you get some into the blood, but it's cleared out pretty quickly. And that's partially because a lot of the drug is being absorbed into through the stomach. And the blood from the stomach goes immediately to the liver, and the liver detoxifies. Means removes drugs from the blood. Whether it's legal or illegal drugs, the liver clears it out. So if you really want a higher level and faster, you need to do an injection. So an intramuscular injection or a single intravenous injection would give you this high peak, and then the liver would clear it out. If you want a continuous high level of the drug in the blood, you have to have, an intravenous, an IV drip that's continuous. All right, toxicity. Drugs are toxic to the kidneys, liver, and nerves. And pregnant women are always at risk for toxicity issues. But there's this measurement called therapeutic index. It's the ratio of the dose of the drug that can be tolerated to the drug's effective dose, meaning the level of the drug that doesn't hurt the patient versus how much drug you need to cause the infection or the negative effect to go away. And so, let's see if I can get a pen here. So if you have, for example, let's say you have a dose of a drug that is, I'm just going to make up a unit, 1. And so if only 1, let's say, milligram of the drug can be tolerated by the patient, but you need 2 milligrams for the drug to be effective, that's going to be a problem, because after you give them 1 milligram, maybe there's going to be bad side effects, but you really need to get up to 2 for it to be effective. So the denominator is the amount you need it to be effective. The numerator is how much, if you go above this level, how much causes toxicity, which are negative side effects. So if you have something like a 1/2, that's not a very good therapeutic index, because you would have to poison the patient in order to get to a level that would allow the drug to be effective. And I'm just making up these numbers to be an example. Now, what if you had a different situation where you needed 2 milligrams of the drug to cause toxicity, and you only needed 1 milligram of the drug to be effective? See, that would be better, because you would be able to give the 1 milligram and it could be effective, and you would not reach the level that would be causing toxicity. And what would be even better is if you had, if 6 milligrams caused toxicity for a certain drug, but you only needed 1 milligram to be effective. So what we're saying is, when you look at these therapeutic indices, the 1 to 2 is a bad therapeutic index. The 2/1 is better, and the 6/1 is even better, because you'd be easily able to give the effective dose and not reach the point of toxicity. So you end up with this overall statement, but you do need to kind of understand what that's talking about, therapeutic index. Another thing that sometimes happens with drugs is that they cause allergies, and there's a lot of reasons why, but you can't really predict allergies. Some allergies just give you kind of a skin rash or hives, but some allergies cause your throat to close up, and you can go into anaphylactic shock, which is very dangerous. So if you have even a mild allergic reaction to a drug, allergic reactions typically get stronger with increased exposure. It depends, but it can get stronger. So if you've had any allergic reaction to a drug, you would want to tell your doctor, so that you probably would not be given that drug again, just in case it might cause something much worse the next time you take it. And then, as I mentioned before, when you give like a broad spectrum antibiotic, what tends to happen, and it's a side effect, is that it wipes out all the normal bacteria, all the normal flora, and you end up with secondary opportunistic infections. The most common is thrush, which is a yeast infection. It can be in the mouth, or it can be in different places, but a candida infection is called thrush in the mouth. So you see this tongue here, this girl, kind of a white coating all over the mouth. That's a yeast infection caused usually by a broad spectrum antibiotic. Much more dangerous is a C. diff, which exists typically in your body, or you pick up maybe some, but if all of your normal flora is wiped out, then the C. diff has an opportunity to grow, and it can be a pathogen. It can be toxic. Okay, resistance to antimicrobial drugs. One thing that's happened as we've used more and more antimicrobial drugs is that bacteria with resistance to the drug have increased in incidence. And the way that the a new resistance initially occurs is by a new mutation. So initially, all new genes have to come as mutations of old genes. So new mutations of existing chromosomal genes. And then once those bacteria have those genes, they can actually pass them to other cells through their pili. So DNA can go across a pilus from one cell to another, and it might carry that gene, that new mutation or that newly mutated gene that gives the bacteria an antibiotic resistance. So we believe that bacteria that have antibiotic resistance occur in every population, and typically they're not a problem, except if you fail to take all of your antibiotics. So even if a bacteria is resistant, you may remember that when a bacteria has resistance to a drug, it doesn't mean that it's 100% resistant. You might still get a small zone of inhibition around that drug disc if you do a Kirby-Bauer test, and we still call it resistant. So it's harder to kill, but not impossible to kill, even a drug-resistant bacteria. But you have to, for a drug-resistant bacteria, you have to give it more concentration of that drug for a longer period of time. And what does happen is people have antibiotics that they're taking for an infection, and let's say 99.9% of the infection is killed by the antibiotic very quickly, but maybe 0.1% has the resistance. And so you feel better because most of the bacteria are gone, and so you stop taking the antibiotic too soon. And what you really need to do is keep up the high level of antibiotic in your blood longer to make sure you clear out the remaining 1 or 2 or 0.1%. I made up those numbers, but 0.1%, for example, bacteria that might have resistance. But if you don't finish out your antibiotics, the few that are resistant will start dividing and create a recurrent infection, but now all of the cells have been the product of the reproduction of that resistant cell. So your recurrent infection is now 100% resistant. And that's going to be much harder to kill. So that's where the problem is when people don't take not taking all your antibiotics didn't cause the resistance. The resistance exists naturally as a mutation in any population, but it exists in a small number of cells in that population. When you don't finish out your antibiotic treatment, what you're doing is you're artificially selecting in favor of the resistant bacteria. They're able to survive, and then they reinfect you. They increase in numbers, and now you have a new infection that's completely resistant. So we decided in lecture to skip this slide. We wouldn't go into all the mechanisms of resistance. And we skipped how penicillin is deactivated. And we skipped this slide, multiple resistance. All right, so we kind of skipped over to this slide, which is what I'm talking about. You need to keep that concentration of drug high in the patient long enough not only to kill the susceptible bacteria, but also to kill the resistant ones. If you don't finish your entire course of antibiotics, you might allow some of the resistant ones to survive and then regrow into a much more resistant infection. And the last thing is sometimes doctors will use multiple antibiotics or multiple antimicrobial agents in a combination, because sometimes what we observe, and we may not even know why, but the drugs act synergistically. So, for example, you have this disc with amoxicillin, this disc with a semi-synthetic drug, and one thing they notice, not only on the agar plate but also in the patient, some drugs, when you use them in combination, you see this area where the two are mixing together, shown in green with this green line, that zone of inhibition is even larger than either one individually. And so you get a combined effect. Synergistically means they work together and give you even a better effect, which I think makes sense. So, how can we fight against resistance? We should only use antimicrobials when necessary. Sometimes doctors prescribe them too much or because the patient demands it, even if they don't think that the antibiotic is going to work. And what that does is if there are some resistant bacteria in there, they will be selected. We do need to continue to develop new drugs and search for new antibiotics. I think I mentioned that the soil there's evidence that the soil has new species of bacteria that we've never worked with before, and they probably produce new kinds of chemicals which can be used as antibiotics. And we're also always trying to come up with new completely synthetic drugs. So research is very important to develop these new antibiotics.